So good evening, one and all, and good afternoon there in Poland. So greetings from India, madam. First of all, I welcome Dr. Aga. To introduce her, she is graduated from the Medical University of Belstock, and from the very beginning of her career, she has been involved in the modern endodontics. She continued her postgraduate education in the field, and in the spring of 2016, she passed her specialization exam with the highest score in the Poland. So, after earning the title of specialist in conservative dentistry and endodontics, since 2022, she has served as a head of specialization in conservative dentistry and endodontics and continuously enhances her qualification by participating in numerous courses and trainings both in Poland and abroad. She is a member of Polish and European endodontic societies, and she is also a workshop instructor and lecturer in the field of endodontics and endodontic restorations. So I really thank Dr. Wasewicz for accepting our invitation on the behalf of IDS Sangli. I again thank you and over to you, ma'am, for your topic.
Thank you. Thank you very much for this kindly introduction. Thank you also for the invitation to Dr. Digvije and Indian Dental Association. Today's topic will be endodontic mishaps and how to safely manage broken files. So I will focus on that topic and also show you some protocols of the bypassing, which I really like, and this is my first choice as well. There was small introduction, but let me tell you something also. Why are you listening to me? And who am I? I am actually an endodontist from Poland, and this is the Poland, our country. It is in the center of the Europe. So I don't know if you've been here, but it is a very nice area. It is exactly the center of the Europe because in Poland there is, according to different studies, there's a city that is a geometrical center of the Europe, and according to different studies, it is Lithuania, so our neighbor. And also sometimes you can think it's Eastern Europe because we used to be a Soviet Union, but it's exactly in the center. A little bit about my dental life. Here on the left, you can see the Profident Dental Clinic that it is held in Kielce city in Poland. And I work there as a dentist. I'm a clinician, of course. And on the right, you can see how our offices, our facility looks like. Also, in the same building, we have a lecture hall, and we have also the space area for the workshops. We make a lot of the workshops from the very basic level to very advanced, and also courses one-on-one. So in English as well, sometimes, yes, because we have lectures from all around the world here in Kielce as well. When I'm not lecturing, I also enjoy to go as a participant to different kind of congresses. It's a great time to exchange the experiences, to get the latest news from the authorities. So I really like and recommend Root Summit and ESC meetings. They're really great. And also what I learned like maybe 3 years ago, it's how to work-life balance. And in free time, I enjoy traveling in the nice sunny areas that are close to the water sports, because I can improve my hobby, which is kite surfing. I think it's not popular in India, but really nice water sport. Okay, and at the beginning of the presentation, I want to put stress that the whole presentation is based on evidence-based dentistry and the latest literature, but also I am a clinician from 14 years now. And as you know, we do not have any particular protocols. We have only some recommendations. So I will also show you what works for me because I do it every day and a lot. So maybe it's also the solution for you. And remember that at the end, we have many different ways to achieve it. And we have to treat this tooth properly, and the patient's health is the most important. So I will start from the basics. So you know that we are not born and raised with broken files inside our teeth, so we break them. And of course, we will speak about the retrieval and bypassing, but we also need to know how not to break the files. So it's good to know some simple rules. And at the beginning, you have to have at least a small periapical X-ray, but I recommend to have two of them because as you can see, on the parallel periapical X-ray, it's just 2D, and you cannot see this curvature, for example, in lower molars that are going from the buccal side to lingual side, also in the upper molars. So it's nice to also have the different direction and shifted X-ray, which I show you on the next slide. Great to have a CBCT because nowadays I think is a must also in endodontics. I'm lucky to have the good quality CBCT at my office, so I also use it and make it just before primary treatment as well, so I can see everything in 3D. And when you already break the file, you know what is inside, but when someone refers to a patient, it's good when he put the note also what was broken, because if it's a small hand file, it's easier to bypass. When it's a big taper reciprocation file, it's the prognosis of bypassing and even retrieval is worse. And what is really, really important, how deep is the file? So when it is the coronal part, it's easy to be visible, to retrieve it. When it's middle third and it's above the curvature, it's also not that bad. But when it's a apical area, I would consider bypassing more than retrieval. And this is the X-ray that I wanted to share with you. It's about this shifting. You can see in the upper left corner that we have a parallel
Sorry to interrupt you,
apical.
madam. I'm not
Yes,
able to see your presentation.
not able to see the presentation, but you
I can
did
see your
see it at,
video.
yes, but did you see it at the beginning or not?
No, 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 madam. No, no,
So you did not at all.
no, no.
So I am
I thought you were.
okay. Okay, so not good. Not good at all. Is it okay now or not?
No.
Okay, so again. Probably
Yes.
here.
Yeah.
Is it fine?
Yeah. Right now we can see.
It's only the presentation or okay. Okay, it's fine like this. Can I continue or should I change something?
Yeah, it's fine.
Okay. Okay, so sorry for that. You didn't see what I was speaking about. Okay, so but I am not going back, I think, but I will start from this part. Here you can see the periapical X-ray that is parallel in the upper left corner. So I can see here in the mesial root that there is one broken file here mesially. But when I shift this X-ray, I see there is another one in the lingual canal. So there are two of them, and that's what I meant to shifting is a good option for that. And this is what I am speaking about, that the curvature you cannot see from the buccal mesial side. So here how it looks like on the CBCT. Okay, from the very beginning, I want to tell you that the plan is okay. Now you see the presentation?
Yes, ma'am.
Okay. So the plan is very, very important. I mean that this is a very good habit to have a consultation with the patient at the beginning to tell him what to do and what we can do and what we cannot. For example, if the mhm. No, ale to inaczej się nie da, bo to nie działa. Sorry, just nie, bo tu się wyświetliło, że w ogóle wszystko trzeba aktualizować i to nie będzie działało. Więc i tak nic nie działa. Sorry for that. He tried to help me. Okay, so the plan and the first visit is very important. I really don't like when the patient is in the schedule without any consultation. I mean, because he or she cannot know what we can do. And here is an example from my clinic. You can see that there is a wisdom tooth and the CBCT taken at our office like 3 months earlier. And the patient treated the tooth outside our office with different doctor. And after 3 months, she scheduled the consultation with me. And I was surprised why and what happened between the visits. And she came to the consultation and told me there is some problem with that tooth because the doctor already took 3 appointments and there was a problem. He's not receiving the full working length to the apex and he scheduled the fourth one to try. And I was okay, not problem. I will see how it goes. It was a wisdom tooth and maybe it's not acceptable to treat it, but she already had 3 visits. She wanted to save it, and she was a young lady with the lack of teeth, and she wanted to procedure with orthodontics after that. And what I told her at the beginning, I told her, okay, no problem, but we have to take the CBCT again. And she was like, not sure about this. Actually, she disagree because she didn't want, she told me that the 3 months or 4 months, it's not a big time and it's pretty fresh. And I told her that, okay, but it's not telling me anything. How is the situation right now? And that was the situation. I encouraged her. I won't proceed if I won't take the new X-ray and new CBCT. And you can see there is a broken file inside. And actually in different shifts, there are 2 broken files. So it is buccal and lingual. And of course, the prognosis is different. It's poorer. The price, the everything, it's different. It's changed. So I proceed and I bypassed the file because it was below the curvature. I couldn't see it. I see that someone tried to make a platform staging to the file, but it wasn't visible at all. It is like third molar, it is mesial root, so very, very hard to visualize the file. And what I want also to put stress on, that even if the patient come to your office today evening and she had the x-ray with her from the morning, but after that x-ray someone uh, took the visit, make the visit with the patient, it could anything happen. So it could be a broken file inside. And if you not make the new X-ray before the visit, this broken file, it will be yours. But if you take the X-ray, I will tell the patient, okay, there's a different situation. You had the visit, you are referred, but it's different that you tell me. So here. From the beginning, the technique of working with hand instruments. So I must tell you, uh, okay, so sorry for that. I will change something in the presentation because it's not visible. I see. Może to wyłącz i wtedy włącz. Ale tego się nie da. No, jakieś, no, udostępnij. Okay, can you
Yes.
see it or
Okay.
not?
Perfect, ma'am.
This one is perfect. Okay, and now you see this one?
Yes, yes. Perfect.
Okay, sorry again. It's today it's not a good day, I think, for this. Okay, so working with hands instrument, it's 30, 50 degrees, like left, right, and minimal movements up and down, like 3, 4 millimeters only. So it looks like this. It's like watch winding technique. So very, very gentle moves, left, right, up and down, and it's this is how it looks like. And what is important to pre-bend the files. So it's a little bit pre-bended in the apical area, so you can go left, right, and easily find the way. So it's also connected with this, what I told you before, that you cannot see all the curvatures. Okay, and here what I like to put stress on also, it's not to jump between the files. So if you are on number 6 and you are switching to 8, there is increasing of diameter 33%. Between 8 and 10, 25%. But I think most of you had the situation that number 10 went smoothly, nice, even it was loose in the canal, and you took 15 and it wasn't that good. There was some forces and blockage working on this file. So there is 50% difference between in the diameter. So I also recommend to use number 12 always. So between 10 and 12, there is a 20% increase of diameter, and between 12 and 15, it's 25. So it's not that much like you jump between 10 and 15. Also, when you are doing a lot of endodontics, I recommend to have the reciprocation handpiece. This one is actually from Cybron Endo. It's 30-30 left-right movements. This is how it looks like. You attach the hand file, the finger file to the handpiece, and you can work smoothly with that. It's very helpful with bypassing. And even if you have some blockage, even if you have some forces that are in the putting stress on the file, it's very, very safe. I haven't broke anything with this. And you can see it is acrylic block. It's a little bit more stiffer than the dentine. And also when you hold it, it's still working. So this one is C Pilot from Fanta, I believe, and even twisted, it's still going on. So we have different reciprocation handpieces from different brands. This one is actually from Cybron Endo, but you have also like NSK, Endocursor, and a lot of the Chinese ones. Just check how much degree they are going left, right. Okay, and here I want to go to rotary files, the stage of rotary files, and no matter of what type of rotary files you have and set of instrument, there are some general recommendation to work with them. And here are the recommendations. Speed is between 250 and 500. It's good to be in the middle of that. It's like 300, 350. Torque will be like 2.5. And I think you will be safe with like over 90% of the instruments that are on the market. And it's good behavior from the beginning to use the manufacturer's recommendation. So see how it goes with your files, but I think this is also uh, very useful. Okay, so the factors influence the lifespan of NITI instruments will be at the beginning root canal anatomy, including canal length. The longer canal is, the more forces act on the file. So when you have like 28 millimeters of working length, it will be more forces on the file. Also, mechanical properties of NITI instruments, I think they are not matters that much as it was in the past because the latest 5 years there are very good martensitic files that are heat treated, so really nice instruments. And what about number of sterilization cycles? A lot of people always ask that. It's not about actually the sterilization because you have in the autoclave like 134 degrees, I believe, and they are heat treated in the much higher temperature. But you have to be careful with the teeth that you worked on. So if you have a very complex case with the obliteration or you did the bypass, so I know the file worked more. I know there are the countries that it is forbidden to use more than once the instrument, but in Poland we can do it, so we sterilize it. And for me, it will be like 3 times. Firstly, for the complex case or the molar, I take the fresh one. Again, I use it to the premolar, then probably to the frontal tooth, and then I will put it on the workshops. Of course, operator skills matters, so do not put excessive apical pressure because you can just break it by yourself. So you have to work very gentle. And what is most important on this slide, I think, it's the kiss and fly rule. So when you are going into the tunnel and you are in this apex area and you want to push a little bit like 1 millimeter more or 2 millimeters more and then it breaks, don't do it. You have to actually be in this apical area even if it's loose, like 1-2 seconds and go back. It's only kiss and fly, 1-2 seconds and go back. And investigation the file under the magnification when you already worked on the file. It's good to look for some distortion, damage, unwinding. Very important to have the proper glide preparation. Coronal pre-flaring, I will speak about this a little bit more, and gentle instrumentation. There are two forces that are acting on our file in the canal. It is the cyclic fatigue and torsional stress. And here it is how it looks like. The cyclic fatigue, repeated use of the same instrument increases the risk to break it, especially below the curvature. So you have to be careful with this with this stages like proper glide path and everything that I already spoke. And here it's like how it looks like. Oh, how it looks like. So when you are using a lot of the same file and you are not going back and forth like kiss and fly, it is, the surface is damaged and it actually breaks at the end. The second force is torsional stress, and here how it is when you are actually your file screwed in to the canal and it is binding in the apical area and the rest is still moving in the handpiece. So you will twist it. And this is another force. And as you see, it was all actually in the apical area. So it's not happening to us when it's the coronal part, it's always in the apical area. When you are thinking where the most frequently broken files inside. Of course, elimination of dentin debris and everything that I here listed, apical patency, so recapitulation is important. And of course, I put stress on irrigation. Proper irrigation activation is the most important, even more than a shaping. So you can use this clean stance that you see on the left, but please do not put the sodium hypochlorite inside. It is the slide from the lecture of Stephen Buchanan. So I don't know if you did know that sodium hypochlorite dissolves NiTi files. And it's actually not something that we cannot irrigate with sodium hypochlorite or something like that. We should. It's like a very long connection with the fluid. When you put actually inside the sodium hypochlorite, it can damage a little bit of the surface. And do not put them into the clean stands. There should be some alcohol, there could be something different, but not sodium hypochlorite. And also be careful with the sterilization liquid. We want to have good disinfection because before we put this into the autoclave, but these liquids also damage our surface. So if you have the information that there should be only 15-20 minutes, it should be only 15-20 minutes, not the situation that our assistant put it on Friday, go to the weekend or holiday and take it out on Monday. It will be a little bit damaged. Okay, so making decision when you already break the file, because we are the clinicians, we do it, we break the files, and according to the literature, it's 6% of the hand files instruments, so stainless steel, but according to NITA, it's 10%. So it's like every 10 cases you broke something. And it is even higher when you are only making only endo, you are the specialist, and it's even 20% because they are treated more complex cases with obliteration and etc. And there is also a study that shows what we do not like the most as a dentist, and the first place take breaking file, broken file, everything around this. And the second place is obliteration, but breaking files is the first that we do not like. So, firstly, stay calm. When you see that you go out with the handpiece with the shorter files, so don't panic, stay calm. It happens, it's normal, it's not that a big deal. Firstly, locate the fragments. So you have to send the patient on the X-ray or CBCT if you can. It's the better, the most important, I think, and it's 3D. And it's also connected with the prognosis of the retrieval. And decide what is your initial step and approach. If you are working with the magnification and you know how to do it, you can just retrieve it by yourself, or if not, just send the patient over. Firstly, consider bypassing, especially for fragments located deep in the canal and beyond the curvature. So if you have a long file inside the canal, you have it beyond the curvature, and you cannot see it. So consider bypassing, and the instrumentarium that you will need to use during that. This is my personal choice. It will be a micro opener that I have always. It's actually a handle file, so I can see everything what I do under the magnification. There are not my fingers in the field, and it looks a little bit like a K file, and I use it instead of Endodontic Explorer, so I can see where the orifices are or where the isthmus is or anything like that. It's pretty sharp, and explore the situation. Also, when you are retrieving the file, you will irrigate a lot and activate a lot, but also you have the liquids inside the canal, so you have to see what you are doing. So the section, the microsection is very, very needed, and you have to do it very quick. This one is from the Polish company that I use. Stropko type irrigator, very nice because you can push the air inside the proper canal. So if you have like completely loose file, you can just take it out because of this pressure of air. Of course, ultrasonics are the thing that you have to have in everyday endodontics. And which device choose, which tip? This one is actually also my choice. On the right, you can see from Dentsply, it is StartX instruments, but I choose the third one. The third one are it's pretty sharp, so I can make also a pre-flaring, enlarge the orifice opening, and it is dense play, but we have also something similar from the woodpecker, and you can see there is a tip called ED53, and it's like 4 times cheaper and works pretty much the same. Also, very thin tips in ultrasonics will be here. You can see the EndoChack tip, and what I use, it's shown here. It is like a smooth tip without any flutes, without any cuts. It's looking more like a spreader, and it's good for the activation, and I use it also for the retrieval to release the file from the dentin. But you have to be careful. The tip should be always sharp, so you can sharpen the tip, for example, with the Soflex disc to be more successful with that. I don't like the tips that have the flutes, because when you are starting with removing dentin or even the only activation, it can break by itself. So only like 3-4 millimeters from the tip, it can break, and it's frustrating. You have also the tips that are already without any EndoChack adapter. They are ready to use. You have here CPRs, some Rido from PDW, but this tree in the middle from Woodpecker also works well. It's E14, ED6, and ED7. They are stiff, they are sharp, so you can also remove the dentin around the file with good visibility. And when you are retrieving the file, and not only then, but always, you have to irrigate a lot. So the Irrigation step, I think it's uh, the most important step during the canal shaping, during the endodontics. And I really like this flexible tips. Here you can see on the left Eddie from VDW, but it is sonic. So sonic it's only, let's say, 6,000 hertz, and ultrasonic it's 30,000 hertz. So the ultrasonic it's always a golden standard. So you should go with ultrasonics, but the tips for the ultrasonics are very, very stiff, and you cannot go like working client -2 millimeters. So again, the woodpecker invented the adapter and the tip. There is flexible, it's polymer, and you can go working client -2. And right now, this is my choice. And here you can see if you have a flexible needle and flexible teeth for activation, you can go deeper inside the canal that you are actually can with ultrasonics. This is a particular ED tip. Okay, about going back to bypassing. What I use at the beginning, it is a Definer file. This is from the Money Company, and I haven't found anything different than that. I think the Chinese companies right now are making something similar. But why this is the file that is recommended? The file is not very active. It has inactive tip. It is quite smooth and only um, and only every few millimeters you have some flutes, so you cannot shape the canal very effective, but you work with this like a spreader because you want to make the space between the broken file, the broken instrument, and the dentin in the canal wall. So you work as a spreader, you make the space. And what is different about these files? It is cross section with letter D, and there is nothing you can just um, like think it is a different file, for example, H file, because you have the letter D on this rubber handle, and they are in the minimal sizes, so only from 8 till 15. It is taper 2 as regular files, and also the length is 25 millimeters with a yellow rubber stopper, and also you have 21 millimeters with white rubber stopper. I will tell you why I choose 21 millimeters for that. Here you can scan also on the profile, you have more information about this. Okay, and the case from the bypassing here, you can see the premolar that is already treated. It was treated somewhere else, and my colleague took the case and he tried to bypass it with definders. And maybe on this X-ray does not look that bad, but when you see on CBCT in 3D, you can see it is S-shape, and you have very deeply this hand instrument broken inside the canal. And also when you see on the next slide, it is a pretty long tooth and already have a lesion around the apical area, and this lesion is connected with the mandibular nerve. So the patient was numb on the side, and the plan B was the surgical case, and the surgeon wanted to make the resection and cut the cut the apex, but I said I can try also. So my friend only could bypass it maybe 21 millimeters. It wasn't enough. And here you can see that I went with this rubber stopper almost into the chamber of the tooth. So it was like 25, 26 millimeters. And when you are bypassing with definders, definders should be pre-curved, make an X-ray and see where are you and if you already bypass properly. So, uh, so because when someone already broke something inside, it can also be a via falsa, it can be ledge, you can go in different direction that you want. So make an X-ray after the bypassing with definder. And here how it looked like, someone already over prepared, I think, the coronal part to make it visible, but in this kind of situation, when you have this big curvature, you cannot retrieve it easily. So consider always bypassing. And here is the movie. It is the movie by Dr. Walid Kurdi, from whom I learned this method about bypassing. And the first start, the beginning, the file that I choose, it is Definder 10. Definder 10 is the first file that you are going into the canal, and it should be pre-bent. You are in the picking motion, so you are actually exploring when you can put a little bit the file to be engaged into the canal between the wall and the file, and this is the catch. And when you have it, you can work a little bit more with Definder 10. Here you can see there is a white rubber stopper, so it is the 21 length. Why 21? Because when it is shorter, it's less flexible and the forces are smaller on the shorter file. So you choose the short file, 21. It is for the most cases, I suppose. When you have like 21, 22 working length, 20, it should be fine. When you have more, choose 25 working length. And here you can see he is using the reciprocation handpiece. So you cannot do it manually, just put on the handpiece and be careful with and gentle with it. Don't push too much, don't make too much pressure, just delicate work. And after you bypass with a number 10, I switch to number 12 and I bypass with number 12. And after this 12, I switch probably to the K files. I use K files, not the C pilots. C pilots are a little bit stiffer, more aggressive, and a lot of them have an active tip, for example, C plus pilots. And you can just also shape the via falsa with the C pilots. I use them more to the narrow canals, to obliterated canals, and here I will choose the K files. So there is then again going on, and the file is bypassed, and then you can proceed with different files. I will show you in a minute how it is done with me here. 10 K file, and it goes this way. And okay, the case that we had at the beginning here, and as I told you, I bypassed the files, and one instrument actually was washed out. And this happens during bypassing because you are making the space between the file and the dentin in the canal wall. So you have the space, and probably the file can get loose as well. So if you are even bypassing, try to put the Teflon tape on the other orifices, because when it's washed out and you are working in the narrow mesial canals, it can just, twist with the liquid and go back to the largest canals, so probably the distal one. So put some Teflon tape there and work with the instruments, then you will be safe. And here was this situation. One was washed out and one was bypassed. And how was it done? Exactly this particular case. I started with Defender 8 because I couldn't find any catch and any space for Defender number 10. I went with 8. And after 8, I use the Defender 10. And then because of the big curvature, I took the rotary files for the glide path, not hand files, because hand files are stainless steel, and they are stiff. So I wanted to not remove more from the curvature, not to make a via falsa, and I wanted to a smooth way, and took the glide path instruments. In this case, it was CPAF Rotary Blue from Fanta. That was my choice because they are very, very flexible. And when you see the sizes, it is tapered too. So the same how the hand files. It's 1302, 1602, 1902. And that was my glide path. And what happened next? You have to be careful because you have a big friction between the file that it is inside the canal and also the file that you are working with right now. So you can break another one. So I go with something very, very small and thin. And here, actually, only file that I could place in that curvature and between the file and the wall was the file that is called F1, also from Fanta. And why is that? Because you have one side totally flat, and it is without any flutes, without any cuts. It is totally flat. And look how many space you have in the canal between the wall and the file. So I could easily go with that file. And I tried many different ones, and only this one could do it. And then after 2004, I went to 2504, and that was it. That is enough. When you are making bypassing, not go with the larger file. I know it's controversial because maybe for someone it's not enough, but with the flexible needles for irrigation and flexible tips for irrigation, I can activate it easily. And for me, that will be this one. Also, what I want to put stress on that in that case, I went from 8 Defender till 10. But with the case of premolar that was S shape and it was very long, it was 25, 26 millimeters. I only could do it with Defender 12, and Defender 10 was too flexible for me. So it depends from the situation. You have to have the whole set, like 8, 10, 20, 12, and then decide and try two different. Okay, here are the silver points. You can see it's 4 of them. For those who don't know what that is, in the past, we put the silver points instead of the gutta percha points because we believed that the silver is high antibacterial. But with the time, we know that they made corrosion inside and became very loose. So it wasn't a good solution to have the perfect 3D obturation. And sometimes you have to take it out, so it could be similar to broken file as well. But be careful because they are very soft and tend to disintegrate. What does it mean? When you are touching these silver points with the ultrasonic tip, it's just crushed and you have like shorter point and it's deeper and deeper. So you have to actually touch the dentin around the silver point, not the silver point. So you have to make space for some tweezers or maybe loops. Yes, for the lasso to take it out. And sometimes when it is very heavily engaged into the canal, I also try firstly to bypass it because I treat it like a very long file. A very long file that is pretty much engaged into the canal. It's very hard to retrieve. So firstly, I bypass it with the definder, then it become loose, and then easily I can just grab it and take it out. And here you can see on the outer wall, there is also a ledge. So it's very popular when you have the retreatment and broken file. So underneath could be also a ledge that you easily can bypass also with definders. And here I took out the 4 silver points, but I left the broken file inside and I just bypassed them. And I could obturate it till the apex area, and also the patient was on the follow-up visit, and nothing is wrong with that. And here, when you can see the second molar, lower molar, on the left, this is the one with the broken files. And here you can see also a big lesions around this teeth, mandibular molar, and also maxillary molars. And here there is also the cortical bone missing, but it was a friend and he asked me to treat this, and I treat also the wisdom tooth, as you can see, but also a second molar here because it wasn't symptomatic at that time, but he wanted some prosthodontics procedure like a bridge or something like this. And in different shift, you can see here that there are 2 broken files on the right picture, on the right X-ray. And I also did not try to retrieve it. I tried to bypass it. And after I bypass it, it just washed out. I just rinse out this with the liquid, with sodium hypochlorite, with the activation. But remember again to put some Teflon tape on the on other orifices. And this how it looks like after here. You can see even the healing after 8 weeks. Why 8 weeks? Because this man was getting the implants and the surgeon wanted to see the maxillary area. There was also some cyst in the sinus, so they checked this, and also I could check how it looks like with the lower ones, and they are pretty stable. Okay, so we have the bypass more or less discussed, and the other option is removal of broken files, which I actually right now do less than the bypass. But firstly, when I learned the possibility of the removal, I removed everything what was in the canal, no matter what the dentin cost was. I had this instrument in my hand, but I left, this tooth very hopeless. So I retrieved the file, but the tooth wasn't with the very good condition. So you have to consider if it's really what are disadvantages and advantages. And firstly, you have to save the dentin as much as you can because it is very biomechanical important. But also I know that we do not want to have these broken instruments inside the canal system. So if it's visible, for me, and I open the tooth and I see the file, or it is very little effort to visualize it. So I try to retrieve it. And I retrieve it with the ultrasonic. So ultrasonic is a must with the broken files. So sometimes it is a regular method and you take out with the only ultrasonic tips. And sometimes you have to uh, firstly use the ultrasonic and then different method like lasso, loop, or microtube, anything like that. So what do I mean about ultrasonic and retrieval? You have to firstly visualize and see the broken file. I will just show you how. And then you have to take a little bit of the dentin around the file. And according to the different literature is like you can have only 1 millimeter and or 1.5 2 millimeters release the file. But if you have a longer file, I think it's not enough to retrieve it. And you are going around the file with this ultrasonic tip. And probably if you have the rotary file, they are working on the right side. So it is good to go on the left side. And then uh, the file become loose. But what to do when you have to, when you do not see the file and you want to? You have to make something that it is called staging platform. So it is more or less something like very wide coronal pre-flaring, and we mostly common you will see in the literature Gates Glidden for that. They are called modified Gates Glidden. Here, something more about coronal pre-flaring and how to save the dentin and be careful with that, with the in the coronal part. And there is a movie, How Do You Modify This Gates Glidden? You cut the sharp tip to make it completely flat because you want to remove the dentin around the file and just to make it visible. And why do I not like the Gates Glidden for that? And maybe it's not the popular opinion, but this not preserve the tissue around. And there are the files that are self-centered. What does it mean? That they're taking the dentin from the outer wall and inner wall equally. So you can have also a strip perforation during that. Here it's also the place that we call danger zone. It was first measured on the lower molars, and from the inner wall, from the furcation area, you can see that there's very, very thin uh, thin amount of the dentin. So when you are going with this Gates Glidden, they are taking on the outer wall and also inner wall. So you are lost and you are already in the bone. And these are actual pictures from our courses. Our participants obturate them, shape them, and then we show them some mistakes. And you can see many different shapes in these molars here, and also C shapes. So be careful with that. So if I do not make the platform staging with the Gates Glidden, I do it with the nickel titanium file because they are more flexible. You can make a brushing more on the outer wall, and they're pretty good with that. They're also modified, so they are shorter, as you can see, and should be also more or less flat at the tip, and you cut this sharp tip. And there are like some openers, also the bigger files. here, so mostly with the 6% taper, but also more narrow one. It depends from the situation. There are actually the files from my office, so I choose different ones. And why it is very, very important. In the tooth, in the teeth, we have something that is called pericervical dentin. It's very, very important part of the tooth. Maybe, in fact, it is the most important part of the tooth. And biomechanically, it is the core because and where it is exactly, it is dentin above and below the bone level, like 4-6 millimeters. And when you remove it, the prognosis of survival of this tooth is very, very weak. And for example, according when you are making via falsa in apical area or perforation, you can just put the MTA, biodentin, you can consider the apical surgery. But here, the researchers, Clark and Kademi, just find out that no man-made material or technique can compensate for the tooth structure lost in key areas of PCD. So when you just remove too much hard tissue around this, you are pretty lost. So that's why I do not like to make big platform staging to visualize the broken file inside. I use more gentle nitile file instead of Gates Glidden. So you can consider this option as well. So when we used the ultrasonic tips, there are some methods to catch the file from the canal system, and here are a few of them listed. But I think that we will focus only on the lasso technique, which is the most popular nowadays. Here is a short movie that shows two broken files inside. And when you have already released the files like 2 or 3 millimeters all around, you can see there is a dentin also missing. You try to put a lasso on that file that is fractured inside, and you push it out one after another. So there are many different lassos right now on the market. And I will show you the one that I use because it's popular in Poland. And there are two, as you can see, taken out. This is the lasso technique and the BTR pen. It's from the Polish company. There are 3 different wires in diameter. The smallest is 0.3, and they switch the color from the pink to the yellow, but it's still the same. It's 03, 04, 05. But this solution is considered right now like pretty expensive because the loops are expensive and they are just one-time use. And sometimes when you have very deeply and heavily screwed in the file into the canal, so they can also easily break. And the first one here is this BTR that I have in the office, so I use it, but I don't know if it will be my first choice right now. Endo Cowboy, Leo Pen, that I think it's popular also in your area, and many different more, I suppose. But you can also make something that it is DIY, and this is the short movie by my friend Olga Zemliakowa. And she is using the needle that was dedicated for the irrigation and also the same syringe for the irrigation. You need to make an incision in syringe plunger like that on both ways. And you have a wire that is molybdenum wire for the LCD reparation on different kind of nitty if you have the wire, some supplier, and you're making your own lasso here, your own loop. You're going back into the syringe like that with this loop. You lock it. And then you put again the plunger that has already in seasons there at the end. And you take around this cuts the wire here. It's like all around to not be removable, and you can, see, you can just tight this on the file and make it smaller, and easily you can do it at your office, and you can have few of them in the shelf, and you will be also happy with that solution. Okay, so we are going an hour now, and don't want you to get bored. But to sum up, of course, the broken file is nothing that is worsening our prognosis, because it doesn't mean anything actually, but it is important to when on what stage you broke the file. When it is very beginning and you did not clean and rinse properly, this could be a problem, because actually the problem are bacteria inside the canal system. So if you did not make a good irrigation, so the prognosis will be a little bit worse. But the worst prognosis is when you have already the apical lesion. So you have some inflammation, maybe this tooth was symptomatic. So this is the factor that can lower the prognosis. But there are some solutions. If you cannot retrieve it, if you cannot bypass it, it's very, very deep, you can consider apical microsurgery. If you are not performing this kind of procedure, you can always send the patient over, but you can also make the good shaping till the broken file and then leave it and observe. But you have to really, really and deeply irrigate with the activation. And of course, it depends how experienced you are, but make a good course, try to do it under the magnification, sometimes on extracted tooth, learn it before you go with the patient. Don't make my mistake. I just took too much dentin around, and right now I'm very, very conservative with that. And thank you for this webinar and this lecture. You can follow for more here on the Instagram profile. Sometimes I also put this on the Facebook profile. And I am really, really sorry for this interferences that were at the beginning and you did not see my presentation. But hopefully you get something from the lecture. Very, very thank you for the invitation as well.
Thank you so much, Doctor. It was very nice and informative lecture on bypassing and retrieval of the files. Very short and concise, short and sweet. Again,
Yes, that's what I wanted to do,
yeah,
because I thought when it will be longer and too much information, you just get bored and nothing, take out from the lecture. So I
exactly.
hope it was fine.
There you go. I again want to thank you again on the behalf of Indian Dental Association, Sangli District Branch. And thank you so much for accepting our invitation to present this webinar. Now I request all the participants, if anyone wants to ask any question, you can unmute yourself and ask this question, or you can drop the question in the chat box right now.
Can you just remind me where can I see this chat box?
Chat box on the right side. Right now, there is no message.
Ah, okay, so no needed. All right. You can just also send me the question directly if you are aware
Yeah, sure, ma'am. I
to
can
ask
if anyone drops in.
now.
Any questions from the participants? If not, we can just end this meeting. I guess there are not.
Okay.
So thank you again, ma'am. So I'll just stop the recording.